Welcome everyone to today's session, MDS 3.0 version 1.18.11. Oh my gosh, here we come. October 2023 is coming soon here. My name is Lisa Thompson. I'm the Chief Strategy Officer here at Pathway Health, and I am joined, as you can see on the next slide here, I am joined by two esteemed colleagues, Colleen Toebe, who is our Director of Consulting Services, as well as Robin Davis, and she's our Director of Regulatory and Reimbursement Services. We are going to spend some time today to talk with you about the MDS changes that are here very soon for all of us as leaders and clinical leaders here in post-acute care, skilled nursing. And those changes are going to be significant. Those changes, as we see, contain some substantial revisions per CMS's announcement, and we know all the information was posted yesterday. And you'll hear a little bit more from Colleen and Robin about that. And it's also including standardized assessment items that are collected across post-acute care and some updated language throughout in order to be gender neutral. So there is a new updated REI manual, an updated MDS, and a lot of things have changed here. So as we move forward here, our esteemed panel, we're going to talk about that high level overview of some of those changes and what it means for all of us in skilled nursing. So Colleen, can you start us out today a little bit about your conversation related to some of the changes and where do we begin with everything that's happening?
Well, I would suggest, first of all, please download the draft MDS manual and not wait till August 1st to hope they've got the final manual out to start going through this. The draft MDS manual has got everything highlighted in red. If you don't know where it is, please go to the MDS 3.0 website and you can download that draft version. In addition to this, we're going to go over some of the top changes that we felt as leaders in this industry that were very important for you to get kind of out of the gate first. There are sections that don't have a lot of changes, and then there are sections that have a lot of changes. The first one I'm going to discuss is really about the importance of race and ethnicity. Some of the things that CMS is looking at is they're looking at outcomes, they're looking at race and ethnicity related to rehospitalization. The updated MDS focuses on identifying the disparity in healthcare, and a collection of ethnic data provides that data. What I'd like to say data mining, but actually data that's important for documenting and tracking healthcare disparities. And it really conforms with our overall Health and Human Services data sets that were issued in 2011. The collection of this data and ethnicity is going to be important in improving our overall quality of care and our healthcare outcomes. This standardized reporting is a mechanism that allows us to look at outcomes in that post-acute care setting that are going to impact the health and well-being of not only our current older adults, but in generations to come.
So Colleen, real quick, before you get into this slide here, so what you're trying to say is all this data is being collected and we're starting to follow that information from one healthcare sector to another healthcare sector. And now it's coming to all of us in skilled nursing, right?
Correct. And the reason we're doing that is that seamless transition. We always want our individuals, our older adults, or anyone receiving care in the post-acute care setting to be in the least restrictive environment. And then we also are tracking not only with ethnicity, but we're really going to be tracking some things on race that are important to understand. When we look at this item related to race, it's an item that you need to provide a uniform language. Now, a lot of people will say, well, I'm Korean, I'm Vietnamese, I've got some other Asian in me, but use your MDS manual. And remember that these categories are not used to participate in a federal program. They are really examples provided by the Office of Management and Budget. So that's why we want to be more exact as far as race and provide those extra choices. In addition to this, the resident may decline to respond, and that's fine. That's fine. So as you're looking at these sections, you're saying, well, some of them aren't going to say anything. It's fine. Or they could be none of the above. So as we looked at race and ethnicity, we're going to look at discharge planning, one of my favorite topics. As an individual comes into the post-acute care center, what are their discharge plans? We know we have to have a discharge care plan from the time they enter. And ask yourself this question as we're preparing to roll out this new MDS: how does transportation impact the discharge potential for readmission? I would just guess that there are people that are living in more remote areas outside the large metropolitan area. And when we're discharging people into these communities, how would they be able to get transportation? Is that an indicator as far as a potential for readmission? The question, although not on all item sets, there is a focus related to the Medicare 5-day PPS, and we're looking at reducing rehospitalizations related to chronic disease. So if they're not able to do follow-up appointment, what is the overall risk for that readmission?
Colleen, real quickly, as you're talking about that discharge planning and transportation, knowing that this is new for us, that we're going to be looking at that coming up here in October, we also know that our other healthcare partners have been looking at this process, as you indicated, how important transportation really impacts an individual's ability to receive the care at the right place at the right time and with the right services, correct?
Correct, absolutely. And that's why you, as providers and leaders in this industry, are working closely with those referring agencies to ensure things are set up before they go home and don't have milk in their fridge. Big question. Can they even get groceries? So they've added some additional choices here. And of course, as we all know, home care referrals are so important to identify related to that discharge status and decrease that risk of hospitalization. Now, Lisa, some of these other changes could be related to med reconciliation, correct? And
You're absolutely right, Colleen. When you look at discharge status and you're looking at discharge planning, part of that process is an appropriate, that transition of care from one setting to the next. Medication reconciliation is one of the biggest areas that really, when we see that if it is not done correctly, it has some potential for negative outcome for our residents and the potential for readmission. So Robin, when we're looking at all this, we see the changes like Colleen was talking about. We talk about discharge planning, transportation, we're talking about, ethnicity, we're talking about race, but there's also a new section as it relates to medication reconciliation, and then also other things such as health literacy, social isolation, and more. Robin, can you tell us a little bit more, starting with medication reconciliation, what we're going to be seeing here coming forward here, and really the importance of that?
Sure, Lisa. We know how important that communication of medication information at discharge is. It's critical to ensure safe and effective transitions from one healthcare setting to another. So we see this new item has been added in Section A, and you need to start thinking about the plan that you're going to put in place to capture this data and to ensure that you meet this, the criteria. We also see in F661 that there could also be some survey impacts here on compliance related to the discharge summary. It specifically talks about the reconciliation of all pre-discharge medications with the residents' post-discharge medications as being part of what we do in our discharge summary.
So when we look at that, before we go on to the next slide here, medication reconciliation, correct, Robin and Colleen, is very, very important. It's not only important to get the right medication as it goes from one setting to the next, but we have to look at the whole picture, looking at what were they using at home. What were they using in our facility prior to them going to the hospital? For example, for the acute exacerbation of why they got admitted into the hospital and coming back to us, that we make sure that we're restarting the medications that are the most appropriate for their care level and the condition level. Correct, Robin? I mean, that's
Correct.
another reason why this is really being tracked as part of that discharge process.
And this includes their prescribed medications as well as over-the-counter medications.
Absolutely. So, when we look at the next slide here, Robin, can you tell us a little bit more? We're looking at all this stuff that we talked about, these different sections, and now we got this whole other area that is really new to all of us, is health literacy, when we're looking at the overall social determinants of health. So Robin, can you just kind of walk us a little bit in this journey around the health literacy and this new area that was brought into the MDS process?
Sure, Lisa. So we can see in that they've added health literacy in section B of the MDS. This is a new item and it's considered a resident self-report item. And health literacy is defined as the degree to which the individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. So this really is how they communicate and what they understand that's being communicated to them from their providers. And in Healthy People 2030, the U.S. Department of Health and Human Services, or HHS, updated the definition of the health literacy to include personal health literacy as well as organizational health literacy. So this isn't just an RAI manual definition. Once again, it's one of those things that everybody is tracking, and we are now tracking that as well.
And you're right, Robin. I mean, health literacy is truly a big data point, not only from a data perspective, but it is very important from making sure that our communication goes from one healthcare entity to the next, and making sure that an individual is prepared no matter what setting they're moving to in the discharge process or the transition of care process. So health literacy is not only are we seeing in the MDS, but to your point, Robin, it is going to become and will continue to be front and foremost as we move forward here in this new era of healthcare. We know the current administration has a big focus in on this for safety and quality perspective. And now we're starting to see it in the MDS. And I anticipate we will be seeing more as we continue to move forward in looking at this journey of individuals going from one provider type to the next provider type in the settings, making sure they get the most appropriate care at the right place at the right time. So another section too, I know section D has some changes as well, right, Robin? If you want to talk to us a little bit about this and what that means. I know there's a little comparison between, really skilled nursing and home health, right, in this?
Yes. We see in section D that the PHQ-9 has been changed to the PH2 to 9, which is similar to what you can see has been being used on the OASIS, which is for home health. We see that in this section now, if the resident triggers for little interest in doing things or feeling down or depressed, the interview ends. And then we look at 7 to 11 days, 12 to 14 days. So we're looking at that 14-day window for this look back period. And you remember to attempt this on all residents. And ask yourself, how will this impact reimbursement? This is one of the items in PDPM that is one of those end splits for depression, as well as in some of the case mix states. And then we also have, if we can't interview the patient for some reason, we are still able to do the staff assessment, but the criteria for the staff assessment is different than the resident interview. So you need to make sure that you read about that in the RAI manual update. And also remember that although it is not stated, CMS suggests that the interviews be completed on the ARD or a day before the ARD.
So you look at all of this and you see, you know, there's these changes and we're seeing the updates. And I know the REI manual explains some of those changes as well. But now another section, and that's really important as we all have, and unfortunately have experienced through COVID-19. And now moving forward here is really that big area that has been discussed over and over. We've seen it in the media. We're seeing it in a lot of information that's coming out from the current administration, as well as things that we saw in the ROP manual and interpretive guidance, is that whole next area of social isolation. And, you know, when we look at this new slide here, this is a section that has had changes. And Robin, can you tell us a little bit more about social isolation? We know this is a big factor when we're looking at this. Social isolation is going predominant in many things as we see moving forward here, 2023 being beyond.
Absolutely, Lisa. So we see a new item on the MDS in section D now for social isolation. The state operations manual addresses social isolation in the context of infection, feeding tube, fecal incontinence, culture, PTSD, and abuse. So when we're looking at this, we need to determine if the resident has been transferred to acute care or if there's been some sort of changing condition, and look for the signs and symptoms of social isolation as well. You know, anorexia, unplanned weight loss, weight gain, apathy, behavioral changes, unusual patterns of behavior, maybe withdrawal. And you know, this item is a resident self-report item, and it really is, it could be actual social isolation or it could be perceived. So as we ask that question of the resident, it is what they tell us.
You're right, Robin. And part of social isolation, when all of us, if we can kind of reflect, if you've gone to a physician or a doctor's visit lately, this has been added in as another one of those screening questions that you see as a standard approach. And you're going to see this everywhere in the healthcare continuum because of what we've experienced throughout the past few years here with COVID-19, as well as looking at the aging demographics and really those changes that could create situations in which social isolation is prevalent in someone's life. So this is not new to all of us, but it is new to the MDS, and we will be seeing more of this as we move forward. And again, using social isolation, then it's very imperative when we look at that, while it's from the resident, but with the other, then how do we integrate that individual into things that are going on in the building, looking at culturally competent, trauma-informed care plans, you know, as we look at the care planning process, and then all those extra interventions. So many changes going on with MDS, and, you know, social isolation is one of them, and the others that we've talked about. But then there comes that big area, Section G or Section GG, right, Colleen? A lot of changes happening. Our good old friend G is going away. GG has
it
got
left
some changes,
us.
right?
Can you believe it? Yeah, it left
I
us.
know.
And I remember looking at Section GG and thinking, oh my gosh, you got to be kidding. They're really going to do this? Well, they did it. So my old friend Section G is gone. Section GG, there are some clarifications made within that new REI manual, and it would be good to take a look at this. They've done some coding definitions related to self-care items such as toileting, hygiene, personal items, dressing, mobility coding, and the updates are through Chapter 3 about with related to Section GG. But as care providers and as nursing nursing MDS coordinators, as the directors of nursing, you got to get prepared, because how are we going to approach this? So this is probably one of the issues that I have talked to quite a few people working in the industry. They're not quite sure, but this needs to be accurate. So This is going to impact reimbursement, maybe on your Medicaid side along with your Medicare side.
Well, Colleen, currently it does, Section GG does impact the QRP,
Yes.
the Skilled Nursing Facility Quality Reporting Program. The 2%, the one side of the 2%, we have the other 2% on value-based purchasing. So now we're adding more into Section GG. So, those review and correct reports are going to be very important as well. You're not only appropriately coding it at the time when you need to code it, but then also making sure we use those reports for our data and making sure that we're correctly doing this. Right, Colleen?
Absolutely. And if you've reviewed the 2023 APU item sets that they're actually gathering data right now on, we need to look at that because there's a lot of things they're gathering data that's going to impact our QRP and our APU for 2025. So this is an area that we need to focus on and make a plan now. In addition to this, as we walk through Section G, there's some other areas that they've moved. They didn't really go away, but they've moved and they've added some different definitions to them. We know that CMS has done some changes here. And I also want to stress the importance that CMS has provided some wonderful videos for training that is on the website. So if you've got questions on what does lower body dressing mean and what does footwear mean, are we capturing everything that we should? And the MDS, the updated MDS, we're going to see some sections that weren't there before, and with personal hygiene. So I wanted to focus a little bit on that. It's just one more thing to think about and to plan for. We're still going to go ahead and talk about being steady or needing some device for transferring. That still is going to impact how we code and as far as related to our survey process. So that is not really changed. It's just kind of moved around with our balance.
And Colleen, as we kind of look at all these changes, not only for the MDS coordinator, but there's going to be changes for the rest of the interdisciplinary team. Especially, I think you're going to move forward and talk a little bit about nutrition. From dietary's perspective, there's going to be changes. We talked a little bit about social services with those changes and all the PHQ, the O2, and then we've got, social isolation, but now dietary and nutrition as well, right?
Absolutely. And when we think about nutrition, I know that we've talked a little bit about culturally competent care and that care plan, but nutrition is huge in everyone's life. We also need to take a look at the nutritional approaches. Some of these questions are going to be on just the 5-day item set. Some will be on all of them. So we're looking at individuals on admission that first time, that days 1 through 3. And it's important that we do a good, thorough examination or assessment based on the information that we've been provided prior to discharge and then that 3-day assessment period. In addition to this, we know they're going to ask well a resident, well not a resident, and then nutrition questions are actually on discharge. So are you asking nutritional questions on discharge right now? Another area that's an opportunity to make sure that we understand, well, they're at home, well, how are they going to receive their nutrition and are they on a special diet?
So when you say that, Colleen, it kind of makes you think about how all this is being brought together. We're looking at the whole person, and it's not only at admission and throughout their stay, but then at the discharge process. Again, preparing that individual to live well, live longer, and do they have the likelihood, or they're likely to not have a stable food source, or not all the nutritional needs met after they leave our organization. So again, this is why this information is being brought in as we look at the overall care of that individual, that beneficiary going through their entry points in and out of our facilities and the whole healthcare system.
Yep, absolutely. Looking at food and nutrition is going to be important to sustain and prevent rehospitalizations. So as we think here, we're walking through the sections, and here we are on section N. We're talking about medications and high-risk drug classifications. Well, you look at these medications, you can say, yes, they're high risk. We know that. We've heard all about this. We know it's in the state operations manual, but they also added a couple, and one of them was an antiplatelet drug, of course, Plavix, and sometimes we even miscoded that as an anticoagulant, but now it's there. And we're looking at oral hypoglycemics, and oral hypoglycemics can be cause a risk also, even though we use them. So they're looking at things that are indications, and we're looking for irregularities. Questions that you may want to address in these high-risk medications is the plan of care. You want to take a look at that. And is there any irregularity? Is there an actual indication? Why are they taking this? And Robin talked a little bit about the need for a medication reconciliation. It's so important because we're going to find out whether or not these individuals have an actual indication for this, or is this something that was started in the hospital that nobody knows about? It also plays a role in determining, last but not least, that wonderful F-tag called F-tag 757, unnecessary medications. Are the medications really necessary, and is there an indication? Sometimes we need to look at medications and talk to your pharmacist and review those medications that older adult is taking. Also, we've talked about med reconciliation and discharge plans. Identifying medications and how they're going to take them at home will be based again on some of these indications for use. And maybe there's some that you can discontinue, or what they call a medication holiday now. So that is conducting that medication review at time of admission, looking at med reconciliation for discharge, and then taking a thorough examination of all the medications and looking at drug regime review very carefully.
And to your point, again, it's really not only doing what you just said, but then, you have your other partners, you have your pharmacy partners and your consultant pharmacist to really, again, part of that interdisciplinary team. We often think about those individuals that are just solely in our organization every day. We have to think about your partners and that impact, because as the MDS continues to evolve, more data, more information is being gathered. And as we all know, the data that we submit through the MDS, as well as our UB04s, is used for many other purposes, not only from population health perspective, but it's from regulatory, from other auditing perspective. But ultimately, us as leaders, we can use that data to help us drive competency, education, opportunities to improve performance. So again, to be able to help our residents live longer and have better, continue to have better lives in our settings. And when we look at not only section N, we got to add more in the alphabet here. Robin's section O with the special treatments has had some changes, and it looks a little bit different. And can you walk us through some of those changes as well, Robin?
Sure, Lisa, it does look different. You can see that there's multiple changes made in section O in the special treatments, procedures, and programs section. You can see that they've added, there used to be 2 columns, now there's 3. And they're different. One is now A, on admission, and then there's B, while a resident, and C, at discharge. So that's very different compared to what we had before. And then you can also see that they've broken some of these items down into more specific items for coding, and the definitions are more specific as well. But remember that there are some items that are only required on the 5-day MDS and not on the OBRA assessment. And as you can see, that previous 14 days before admission, that column has gone away. So that is where section O is now.
So section O has gone through changes. And again, as I said in the beginning, we're only doing a high-level overview of the changes. There are many other, definitions, interpretations, things that as we start rolling out, the draft RAI manual came out. We just got all the information came out yesterday for all of us as we as well as many other organizations are looking at it and delving into in further detail. There'll be more education and opportunities out there. As Colleen indicated, CMS has put out some great videos, short videos that help us with coding certain sections, as well as give us great education. And those are good tools to use as competency base for your MDS coordinators, as well as other interdisciplinary team members. But also another change that happened here, Robin, can you talk about the care area assessment summary has changed? And see all those
Sure.
reds on there? Boy, here we go again. More updates and more changes, right?
Yep. So of course, with all these MDS changes, there is going to be some changes to our cause, the triggers and the summaries. So it's going to be very important to take a look at the manual, chapter 4, read it and get to know what those changes are, and then review that with the IDT so that everyone's aware when they start doing their cause come October 1, that there's changes.
And knowing that those changes, we have to be prepared and ready. So that kind of leads us, Colleen and Robin, into those next steps. And we're looking at as leaders, as clinical leaders, as MDS coordinators, as members of the interdisciplinary team, as we're trying to learn a little bit more. What are those next steps? And, Colleen, as we do this, we prepare ourselves, we get our education, but we have to have a plan in order to implement those changes. So you can kind of walk through some of those challenges that we might see right now, Colleen, and then some recommendations as we start moving forward. Colleen, I'll let you start it off, and Robin will keep on moving forward here as we talk about those changes here. So Colleen, talk a little bit about those challenges. Boy.
So some of those challenges, and I know that we're probably challenged right now, but when we think about the challenges, we're going to take a look at your whole organization and focus this not on just the MDS person. This is an organizational change. We need, think about it in the big picture. So who needs this additional training? It's not just the MDS nurse. You could see that by, we've taken that high level of overview. Has your organization had discussions? Are we hoping everything in our software is going to work fine come October 1st? Have you had any of those discussions with your software vendors? And then what are your plans to provide education and training of your MDS coordinators?
So when you look at it, Colleen, there are some organizational strategies, like you said, it is a bigger picture. I mean, I'm not an MDS coordinator, nor do I profess that I am an expert in the MDS or the REI process, but I do know enough that as a leader, I have to start preparing. So in helping my team prepare and get the right resources and the tools in place, can you walk us through some of the things that we might need to do, Colleen? And then we'll talk a little bit with you, Robin, as well.
Well, when I think about organizational strategies, I just mentioned that this is not just the MDS nurse. So I'm hoping more than just MDS nurses are listening. This is organizational change, right from having that administrator involved and understanding this is a lot of information and we're going to have a lot of changes. But take a look at what is working in your current processes right now and make sure that we not only look at this, we should read this draft MDS manual, please. I don't know if there'll be a lot of changes, but you need to take it, open it up and take a look starting, and maybe you want to go through one chapter a week or some type of strategy that you could take a look at those sections. Make sure that your organization really has keeps abreast of any EMR changes. We understand that we're going to iKeys really soon, and I know you're probably all prepared for that, but look at that process that you're doing and try to make a seamless transition. I remember MDS 3.0 in 2010, and it was very challenging for many of us. So I've learned from that by preparing, looking at the draft MDS, looking at the item sets, kind of looking at policies and procedures. How are you doing things now? What would we like to change? And then I'm just going to mention one other thing. You've got to look at section GG and how you're going to work collaboratively with an IDT team to complete that accurately.
You're right, Colleen. And, it kind of takes us to that in the next slide here is, Robin, really as a leader, if you bubble it back up, like you said, it's a bigger picture approach. And Colleen was, again, reinforced that as well. And again, to everybody here on the call, we did not delve into detail of all the changes and all the things that are occurring. This is a very, very minimal high level. Again, there's opportunities for all that training. As we see here on the slide that you prepared for us, it's like we have to look at training and how do we get our resources put together. See, kind of want to walk us through here, Robin, about those next steps here for us.
Sure. So as Colleen mentioned, this isn't just your MDS coordinator. So you need to be thinking about budget for training, not only MDS, but the interdisciplinary team, and then also your licensed nurses and your CNAs. And there's going to be quite a bit of training that needs to be done. Who all needs to be trained? Think about that and think about what they need to be trained on. Develop that action plan. Think about what needs to be done and who is responsible to do it. Think about and look at your processes, your policies. How are you going to collect all this new data? How are you going to do that? Look at your EMR or your electronic medical record, or if you still have paper charts, what forms need to be changed. There's a lot to think about when you look at each one of these areas and the changes that are coming. And then schedule that training, get it on the calendar. It's a lot of training, so you're not going to be able to do it all at once. Maybe you want to do it over several months. You need to figure that out now and have that plan in place to go forward.
And we know, Robin and Colleen, I know CMS has announced that they will be hosting some training in the summer, which is going to be great. It's a foundational training, but again, that's an overview training specific. It's going to be in complete alignment with the RAI manual, but it does not then dig into, as your point, Robin, into your internal processes and all the things, your policies and procedures and everything else that are going to be affected by these changes as well. So, definitely the CMS training has to be part of the process. You have provider training that's available. That'll be, the Provider Association training that will be coming available. And I'll talk a little bit here shortly about some of the things that Pathway will be doing. But then on the next slide here, again, the big question, like we talked about, and Colleen, you said that, and Robin, I know the accuracy of the section GG. I know I was looking at both of you nodding your head, and I've been getting a couple little chats from people as well saying, we know section GG is going to be very, very important as we move forward here. But can you, Robin, just talk real briefly here as we get to the point of we're going to do some final thoughts here, ICD-10 coding and the importance throughout this process, because of course there's going to be changes with that too coming up, right?
Yes, there are. And you need to look at who's doing your ICD-10 coding, and do they need more education, and get them what they need so they're well educated and they can properly code those diagnoses. And we already talked about GG, how important that is, and look at that process. Are you doing that as an interdisciplinary team? Not just nursing, not just therapy, but you're coming together and coming up with that function. And then your RAI process too needs to be multidisciplinary. It can't just be the MDS coordinator who is completing every section and every CA. It needs to be the interdisciplinary team.
So when we look at all of this, all of us as leaders in this industry and individuals that work throughout this whole process and know the impact, all of us knew this was coming. It's not new. It was told. We've been anxiously waiting for these updates. So how do we move forward and how do we get ourselves prepared? Well, I do want on the next slide, we will, and I know there were a couple of questions that people were asking is, will Pathway have information available? Will Pathway have the slides available? Will Pathway have some tools and resources? And yes, we will. We are going to be launching here in a couple of days, and all of you that are on this this webinar will be receiving a link to that for some complimentary tools and resources that actually walk you through the things that Colleen and Robin were talking about today as you start to develop your transition plan and create that plan. You know, it will walk through the successful transition, then it will walk through every single section of the MDS that has changed and corresponding that with the REI manual as well. Pathway will also have education, additional tools and resources, and specific education for specific disciplines, as well as the overall education for the MDS coordinators. So as we wrap up here today, and knowing, you know, yes, Pathway is a partner in your process throughout this, and you know that you can always reach out to Colleen and Robin, you know, ask specific questions. Of course, you can ask me, but I won't be able to answer the specific MDS questions, but I'll make sure that our experts will help you, and our team of clinical reimbursement specialists that would be able to help that work with Robin and Colleen. But Robin and Colleen, any final thoughts as we wrap up our session here today with everyone?
Well, my final thought is just prepare. Pathways available to help. We have excellent consultants that work in this field daily, and we're well aware of the challenges that you're going to face, but just prepare. Don't panic. Don't panic. It's going to be all right. We're going to be there to help you through this. That's part of our, we're available to you, and we will have education and resources for you. Robin?
Yeah, yes, that's my exact same thought, is to prepare now and don't wait until the last minute. You know, it's easier when you have a plan and you're proactive and you get the things in place that you need to before October 1.
So we want to say thank you again. Thank you, Colleen and Robin, for being on this call today. We know that, you know, as they indicated, Pathways available to help you. But again, to everyone as leaders out there, it is change. We're used to change every day. Unfortunately, this is a big change. It will impact not only how we do business every day, it will be impacting our interdisciplinary team, but it will also be impacting our data and our outcomes and how that data is utilized by external entities as well. So the importance of it is not only getting it right internally, we want to make sure that our data is so it accurately reflects the individuals that we take care of and the great care and services that you provide every single day. So on behalf of Robin and Colleen and Pathway Health, we want to thank each and every one of you for joining us here today. And again, we look forward to providing additional education and resources coming forward here. So stay tuned. October 2023 is coming soon, and Pathway's here to help you. Thank you for joining us here today.
We do have a question. Colleen or Robin, could you address the question in the Q&A?
Is this the one on B1300?
Yes, it is. So the
Um,
question is for B1300, if a resident is a DPOA or guardian, would the health literacy apply to the guardian DPOA or still be based on that resident? Colleen, can you answer that for us?
No, I can't. To be very honest, I would have to take a look it up. Holly, could you possibly go ahead and give me your email, or the email will go ahead and post that? Unless we can, I got to find the manual because I haven't memorized this manual. Robin, do you have your manual up? Huh?
I do. Let me get
she
it
does,
up
yeah.
to 1300. And I believe
It'll apply to the
what the
guardian.
manual says. Let me get there real quick here. That it still is based on just what the resident
Just what the resident said.
Yeah, which
Resident centered.
so yes, so here we go. So steps for assessment. This item is intended to be a resident self-report item. No other source should be used to identify the response. And so you are to ask the resident the question, and you go by whatever the resident tells you.
So Holly, you know, you put a response in here in the Q&A and you said that you had looked it up and it's reading as the resident centered. So absolutely. And we reconfirmed with the REA manual. And again, all of us, we just got the REI manual out yesterday, and so I'm sure we will have more questions like this. And please feel free, you can go at Pathway Health. So it's www.pathwayhealth.com, and there's a contact us, and you can always ask questions and send that in. And Robin and Colleen get those questions. They'll be able to answer those questions directly. So without having any other questions, we want to thank everyone again for joining us here today. And again, Colleen and Robin, thank you. And thank you, Robin, for looking that up in the REI manual for us. We all transition and move forward here through these changes with the MDS process. Thank you for joining us and taking your time out of your very busy days.
Bye-bye.
Bye-bye.
Colleen, can you scroll through the rest of the slides with the references and so forth?
Yep.
Thank you.
There.